All right, so tonight we're going to go over medicine section. So we know that medicine section will be for any services that are not evaluation and management. They're not any actual surgical procedures. So you're going to see a lot of things like vaccines, dialysis, chemo, ophthalmology, acupuncture, chiropractic. There's just a bunch of things, right? So it's kind of a hodgepodge kind of section. But the easiest way to just kind of do it is just dive into it and just do some scenarios. So just the big thing to remember, like I said, is they are services that are not going to be considered surgical in nature, or they don't fall underneath an evaluation and management service or anesthesia. Okay. So let's just jump in to number one. We have a 59-year-old male experienced left arm pain while cleaning the garage. There's no injury, and his provider scheduled a 30-minute stress test using the Bruce protocol at the hospital. There was no arm pain while on the treadmill, and he did have a slight heart rhythm abnormality. The patient rested for 2 minutes and had no further symptoms or pain. The cardiologist supervised the study and interpreted the test as well as dictated the report. So, what code are we going to use for our stress test? Okay, so let's look at this from a process of elimination standpoint. Okay, so we have two options that we can look at. We can either look at 93015 because it's in A and B, or we can look at 93018. So which one do you think we should go look at? Or which one do
93015.
you guys want? Okay, let's just look. Yep. I mean, they're pretty close together, but that's the first one that we'll focus on. 93015. So your 93015 code description is for a cardiovascular stress test using maximal or submaximal treadmill or bicycle exercise, continuous electromyocardiography, myocardiographic monitoring, and or pharmacological stress. And it is with supervision, interpretation, and report. And then we have the 93018 that is for the interpretation and report only, as well as we have one option with 93016. Okay. So with your 93015, this is going to be a global package with including professional and technical components. Okay. So the 93015 is they did everything, including the supervision, interpretation, and report. So since they are at the hospital, okay, so this is our key word or our key phrase in this scenario, is they were at the hospital. So this is indicating that the provider does not own the equipment that they are using to do the stress test, but he has supervised the study and then he has interpreted the test as well as dictated a report. So we would not use our 93015 because that is including everything, right? Including saying that they own the equipment. So it's including the technical component as well. So in order to correctly report the supervision of the study as well as the interpretation and the report, how would we code this scenario? What do you guys think?
93016, 93018.
Yep. We're going to do
Final answer.
93016 and 93018. So our 16 is going to be for the supervision only. And then the 18 is going to be for the interpretation. Well, if I can get it to, there we go. That's going to be for the interpretation and the report. Okay. So if you see a scenario like this where 93015 includes supervision, interpretation, and report, then we should report them separately because if they are at the hospital, we know that the provider does not own the equipment. Does that make sense?
Can you say that again? Sorry. Sorry about that.
So your 93015 is going to include your professional and your technical component because it's including the use of the equipment that they own. However, because they were done, the stress test was done at the hospital, then the technical component is going to be billed by the hospital. So we have to separate out the professional components individually to bill for the provider. So we're going to bill the supervision separately and then the interpretation and report separately. Okay. Let's take a look at number 2. So number 2, we have a 70-year-old patient with chronic obstructive asthma, and they're brought to the urgent care center with increased wheezing and coughing. The provider initiated an albuterol inhalation treatment, 1 dose delivered by nebulizer. After treatment, the patient's exacerbation has somewhat improved, but the provider determined that a second treatment was necessary. So they did a second treatment. So what codes are we going to report? So do you guys want to look at this from an ICD-10 standpoint, or do you want to look at this from a CPT standpoint first to rule out? Any preferences? Okay. So I say let's look at ICD-10 because we have 2 that have J44.1. So we can either confirm B and D or we can rule out B and D. Okay. So let's go look at J44.1. So J44.1 is your chronic obstructive pulmonary disease with acute exacerbation. Does that sound like what we've got? So chronic obstructive pulmonary disease with acute exacerbation. Yep. So J44.1 is going to be our code for ICD-10. So we're going to rule out A and C. So now we have, let's look at our CPT codes. So we have 94640 twice and 94664. So those are pretty close together. So let's just go look at those real quick. So 94664 is going to be for a demonstration or evaluation of patient utilization of an aerosol generator, nebulizer, meter dose inhaler, or IPPB device. So does it sound like we did either a demonstration or an evaluation of patient utilization of that nebulizer?
Mm-mm.
Right. So that's not it. So let's just go look at the 94640 just for our knowledge. We know that our answer is D, right? But let's take a look at those codes just that way we can get familiar with what they look like. So 94640 is a pressurized or non-pressurized inhalation treatment for acute airway obstruction for therapeutic purposes and or diagnostic purposes such as sputum induction with an aerosol generator, nebulizer, meter dose inhaler, or intermittent positive pressure breathing IPPB device. So, and then we have parenthetical notes underneath that tells us for more than one inhalation treatment performed on the same date, we should append our modifier 76. So because we had the first inhalation treatment here, and then we had a second treatment that was delivered, that would be our 76 94640. Okay, does that make sense? While we're reporting 94640 twice, one with no mod and one with a 76 mod. Now, I know we haven't talked a whole lot about HCPCS codes, okay? But let's look up this HCPCS code so that way we get familiar with how to use our HCPCS manual, okay? So with our treatment, he is doing an albuterol inhalation treatment. So he's doing an albuterol inhalation treatment. Okay. So underneath our table of drugs and biologicals, we will go to albuterol because that's going to be what we're billing for, or what we're coding for is for the actual drug that he did the inhalation treatment with. And then you will look for albuterol. So with your albuterol treatment, we are going to assume that it is compounded, okay? Because with they would have to specify that it's non-compounded in order to use that. So if we have a unit dose of compounded albuterol, we would go to albuterol unit dose compounded, and then our route of administration is inhalation, and it's going to give us our J7609. And again, we're going to use 2 units because we have to provide 1 unit for each of the treatments. That makes sense?
Yes, Tiffany, I have a question.
Yeah.
So we have just gone to the J 7609 in our HCPCS book to kind of
Yes. Yeah.
rule
If you
in
were
on
using
that.
process of elimination, but like I
Okay.
said, we haven't used HCPCS a whole lot in
Right.
any of our study sessions. So I at least wanted to make
Okay.
sure that you guys knew how to
So look it up.
use your
Okay.
HCPCS manual if you do have to get to that point. Yeah.
Okay. Okay, great.
Yes. For
Thank
testing
you.
Yeah.
purposes, absolutely. You can go
Okay.
directly
I
to the code.
Okay,
But
I
great.
think if
Thank you.
anything, Hicks might be the easiest code. Is the easiest
it
code
is.
to look up.
It is. It is definitely the easiest book to use, which is why I don't really touch on it a whole lot because I don't want to waste time whenever we can really be focusing on CPT and ICD-10. And that's where a majority of the people struggle. But like I said, since we had it here in front of us, I wanted to at least touch on it. Okay. Let's look at number 3. So a teenager has been chronically depressed since the separation of her parents 1 year ago and moving to a new city. Her school grades continue to slip, and she has not made any new friends. She has frequent crying episodes and is no longer interested in her appearance. She has attended the community mental health center and participates in group sessions. Recently, her depression exacerbated to the point that inpatient admission was required. The provider diagnosed adjustment disorder with emotional and conduct disturbances. Due to the length of the depression and no real improvement, the provider discussed electroconvulsive therapy with her mother. After discussing benefits and risks, the mother consented to the procedure. So we are only reporting for the electroconvulsive therapy. Okay, we're not doing anything else for the inpatient admission except for our electroconvulsive therapy. So process of elimination wise, let's take a look because our F43.25 is in both, right? Or is in all 4. So let's look at 90870 for process of elimination wise, see if that's our code for the electroconvulsive therapy. So our 90870 is for electroconvulsive therapy and it includes any necessary monitoring. So pretty straightforward, pretty simple, right? So that's telling us that B and D are going to be one of our valid options. Okay. So now let's flip to ICD-10. And then we know F43.25 is in both. However, what we need to do is we need to see if there's anything in that F43.25 that indicates it's a combo code, to see if we need to code something in addition or if everything's going to be included in that F43.25 diagnosis. Does that make sense?
Yes. And I think it is
Okay.
F43.25 because I'm looking at it
Okay.
right now.
So
Because
F43.25 is our adjustment disorder with mixed disturbance of emotions and conduct. And then F43.24 is adjustment disorder with just the disturbance of conduct, not emotions and conduct. So because we have here our adjustment disorder with emotional and conduct disturbances, then do we think that the F43.25 includes everything, or do we think we need the additional code?
I think F43.25 includes everything.
Mm-hmm. Yep. Because it specifically states mixed disturbance of both emotions and conduct. Yep. Okay. Any questions on that one? Okay. Let's go to number 4. So number 4, we have a 30-year-old male that cut his right hand on a nail repairing the gutter on his house. 6 days later, it became infected, and he went to the immediate care center within his neighborhood, and it's his first visit there. The wound was very red and warm with purulent material present, and the wound was irrigated extensively with sterile water and covered with a clean, sterile dressing. An injection of Bacillin CR 1.2 million units was given. The patient was instructed to return in 3 to 4 days, and the provider diagnosed the open wound of the hand with cellulitis. There was a medically appropriate history and exam with a straightforward MDM present or performed. So even though we're in the medicine section, okay, our actual visit with the provider is going to be represented with an E&M code, right? Because they're telling us that we have a medically appropriate history and exam. So that's going to be our evaluation and management code. But let's look at this from a medicine perspective. Okay, because we haven't really talked to E&M too much. So I don't want to dive too much into E&M. I only want to look at this from a medicine perspective for the case. So from a medicine perspective, the procedure that we're going to report with a medicine code is going to be the injection itself of that Bacillin CR. Okay. So that's going to be something that's found in our medicine code, is just reporting the administration of whatever the injection is. So let's do this one from a coding from scratch standpoint from a medicine perspective. Okay. So in the alphabetic index in your CPT manual, the alphabetic index, we're going to look up administration. Oh, nope, we're going to look up injection. Sorry, not administration. I always forget that it's not under administration. It is under injection. And then underneath injection, since it is a antibiotic, which is our Bacillin CR is going to be an antibiotic, then we'll go down to injection and then antibiotic. And then that tells us specifically that we should see antibiotic administration instead of injection. So let's go to antibiotic administration. And then you've got injection under that, and that gives us what range of codes for the administration of that antibiotic.
Nine six three seven two. That's one of them.
Mm-hmm.
Hang on, looking right now.
So 96372 through 93679, right?
Yes, that's correct.
Okay. So which of those codes in that code range do we think we're going to use for that antibiotic administration for this scenario? So was it given intramuscularly? Was it given intraarterially, intravenous push, anything along those lines? If they don't indicate, then we can assume that an injection is given intramuscularly. Okay, so just keep that in mind. So we're going to use for the administration portion of the injection, we're going to use 96372. Does that part make sense?
Yep, and now we know what our answer is.
Well, not necessarily, because we have two 96372s.
Oh,
Yep. Because we have to consider we're also giving our MDM, we're also giving an exam before we do the injection. Okay. So if you don't know if you're 100, if you're not 100% sure if you should code the ENM separately, okay, you can always look at it from a standpoint of we've injected something, so now we have to report our HCPCS code for the actual supply of the drug or the antibiotic, right? So we know that our J codes, from a testing perspective, we know our HCPCS codes, our J codes are going to be the actual drug code, right? So if we know that our drug code can be billed in addition to the actual administration, then we know we have to bill that separately. So that's going to give us our answer, because we have to not only bill the 96372 for the actual injection, but again, we have to bill the substance that we don't have to, but we should, right? We should
where
bill it
does it
because we
say?
want the
Where does it say
what?
where does it say in the scenario the injection penicillin, the J0058? Where does it say that? I'm just curious.
It's the Bacillin CR.
Oh,
So whenever you look up your drugs in the alpha or in the table of drugs and biologicals in your HCPCS, and you
I
look
think
up
I
for the
get it.
Bacillin CR, it's going to give you your J0558. And
I
then
think I
based
get
on the
it.
number of units per code, that's why we build 12 units.
Yeah. So I think I get it. I wasn't trying to cut you off and I wasn't annoyed. It was more just like a so you code the injection separately and then you code the then when you need to code the specific type of drugs, then that's when you get your HCPCS book out.
Correct. Yeah. Yeah, because if we inject something, we have to let the insurance company know what it is that we injected so that we can get paid for it. Because our injection is just the act of the medical assistant or the nurse or the provider actually inserting the needle into the tissue, right? But we don't know what we injected without that additional code to tell us what it is. Okay. So, Abigail, in this scenario, you wouldn't bill for the irrigation because they're not doing a procedure. They're not doing any closure or anything like that. He's just cleaning it out. So that's going to be considered part of your E&M code, because there's not really a surgery or a procedure that was being done. The irrigation was just making sure that it was clean. And it wasn't to the point of it being any debridements or wound cares or anything along those lines. Does that make sense? Okay. Any other questions on that one? So even without us having to look at our E&M code, right? Since we're in the medicine section, I wanted to at least go over ones where you might see and you're like, hey, I'm not 100% sure if I need to bill my E&M separately. So we can rule things out in multiple ways. Okay. Number 5, so patient has an open wound on his left lower leg that was caused by a cat bite. The animal tested negative for rabies, but the wound has failed to heal and it's become infected by Clostridium perfringens. The patient underwent hyperbaric oxygen therapy, attended and supervised by your provider. So what are our CPT and ICD-10 CM codes? So let's look at this from a process of elimination standpoint. We aren't going to be able to rule out with ICD or with CPT, right? Because they're all different codes. So let's go look at our ICD-10 codes.
Okay.
We have 2 that have S81.852A. So let's go look at those and see if we can confirm A and D or if we're going to rule out A and D.
S81.852. Okay, S81.852A is open bite, lower leg, left lower leg.
And then our A is for the initial encounter, right?
Yep.
So do we think that's our answer? Or at least our ICD-10 code for the open wound?
That's one of them. That's what I think is one of them.
Mm-hmm. Yep. Okay. So that's our open wound. So let me highlight that so that you guys can see that. Okay. And then we know that W5501XA is in both, right? So now we just need to see, is that B96.7? Do we need to use that code as well? Or do we need to leave it well enough alone? So let's go look at the B96.7.
Yes, I think we do use it.
Yep, because it's that Clostridium perfringens. So we should report that. Okay. So we're going to rule out D, and we know that A is our answer.
And then W5. So yeah, like if it comes to bites, like by an animal, you code the wound first, and then you code what the resulting infection is, and then you code that it was bitten by a cat.
Yep, the external causes should always come last. Your external cause code should never be the first listed diagnosis. Correct.
Yeah.
Okay.
I wish I had matrix programming and I could program this all into my brain.
I know. All right, let's do number 6. A patient mangled his left hand in machinery requiring an amputation at the wrist. The wound has healed and the patient is fitted with an artificial hand. And the device has a molded socket, flexible elbow hinges, and triceps pad. A total of 30 minutes was spent training the patient how to use the prosthesis. So let's look at this from an I keep saying an ICD-10, from a CPT medicine section. Okay. So let's look at 97761 because that's in 2 of our options. So we know that's more than likely correct, but we never want to just automatically assume. We always want to go verify that code. So 97761 is prosthetic training, upper and lower extremities, initial prosthetics encounter, each 15 minutes. So that sounds like what we did, right? So we're going to rule out C and D. Yep. And then Dawn, you're right. So because we know we did a total of 30 minutes, we can automatically assume that it is letter A because we have to account for the full 30 minutes. And each one of the units for 97761 is for 15 minutes. So we can report 2 units. So looking up a single code was able to give us our answer. Okay.
Wow, that's
Any
amazing.
questions on that one? Yeah. Yeah. So process of elimination from a testing standpoint will definitely help you with speed and confidence for sure.
Yeah, it's
Okay. So let's
just
look at number 7. We have a 54-year-old female with uncontrolled type 1 diabetes or insulin dependent diabetes and related peripheral vascular disease, and they present with a deep diabetic ulceration on the bottom of her foot, her right foot. The wound is necrotic, reaches to the fascia, and appears to be draining. She does acknowledge going barefoot frequently and is not certain how or when the wound occurred. After the provider discusses the seriousness of her condition, he debrides the wound using a water jet and surgical scissors. Size of the wound is 70 square centimeters. He applied topical ointment and a sterile dressing. He counseled the patient about the need to wear shoes at all times and inspect her feet daily. He advised the patient to wear a water protective covering on her lower leg when taking a shower and to change the dressing daily using ointment provided. A surgical shoe was provided, and the patient is to return weekly until the wound heals and continue her insulin regimen. If satisfactory progress does not occur, a graft may be considered.
okay. Here's
So,
something
do you want to? You're fine. Go ahead.
I see that L3260 is in 3 of them, so it's got to be at least A, B, C, or D. A, B, or C.
Okay. So
That's just
you
what I
can
think. But
do process of elimination that way. I like to do it to where we can rule out as many as possible, right?
got it.
So even though, yes, we are ruling out letter D, right? We do have an option to rule out more than one. So let's look at the 97597 and see if 97597 is our code. So 97597 is debridement of an open wound, including any topical applications, wound assessment, use of whirlpool when performed, and then instructions for ongoing care per session with total wound surface area is first 20 square centimeters or less. Yep. So 95797 is one of the codes that we need to choose, right? So if we had a total size of 70 square centimeters, right? Our 95797 is the first 20 square centimeters. We need additional codes, which are our add-on codes underneath, which is the 97598 for each additional 20 square centimeters or part thereof. So our first 20 is represented with 95797. Then we need a second, we need another 97598 to represent 21 to 40. We need another one to represent 51 to 60. And then we need a third unit to represent 61 to 70. So that's going to give us our 97598 times 3. So that's all we had to look up in this scenario. Again, from a testing perspective, because we were able to say that we need that 97597 for the first 20, and then 3 units of the 97598 to get us all the way up to 70 square centimeters. Now, let me ask you guys this from a critical thinking standpoint. Okay. He talks about how she is on insulin, right? Why are we not coding our Z79.4 for long-term current use of insulin with this scenario? Any thoughts? Because we know we have a guideline that states if the provider indicates that the patient is taking insulin long-term, that we should report Z79.4 for that long-term current use of insulin. So why in this scenario are we not reporting Z79.4?
Yeah, we are not supposed to code the Z codes with E10.
Well, because they're type 1. So yes, that's essentially what it is. But it's not, there's not anything that indicates you cannot code Z79 with an E10, but we know that a type 1 diabetic is going to require insulin to keep their diabetes under control. Yeah.
Yeah, so it's like a temporary diabetic management. It's like a temporary diabetic management. That's why.
No, it's not a temporary. E10, it represents our type 1 insulin dependent diabetes, right? So if type
Right.
1 always requires insulin, then the Z79.4 would just be redundant. Where the temporary rule comes into play is if you have type 2 or another type of diabetes and they're only given it once or twice to bring their elevated blood sugars into control. Does that make sense?
Yeah, makes sense.
Okay. So I just wanted to at least test you guys on that guideline, see if you remembered. So remember, type 1 diabetic does not have to have your long-term current use of insulin, because we can assume if they are type 1, they are long-term taking that insulin to control their blood sugars. Okay. Any questions on that one? Okay. Let's look at number 8. A young child received a mumps, measles, rubella, and varicella injection, or an MMRV, at a neighborhood clinic with provider counseling. So what CPT codes should we report? So let's go look at 90707. So 90707 is for measles, mumps, and rubella virus vaccine live for subcutaneous use. But it doesn't include the varicella portion, right? It only includes mumps, measles, and rubella, the MMR, not the MMRV. So, yep, Xenia, you're correct. So one code down, the 90710 includes mumps, measles, mumps, rubella, and varicella, which is your MMRV. live for subcutaneous use. So we are going to use 90710 instead of the 90707. Okay. 90460 is in both. So let's go look at 90461. So 90461 is an add-on code. Okay. So
What
90460 is
where can I find it in my book? I'm on the medicine section. It's just hard to find.
page 745.
Ah, sorry about that.
You're fine. So 90460 is the immunization administration through 18 years of age with any route of administration with counseling by our physician. First or only component of each vaccine or toxoid administered. And then 90461 is for each additional vaccine or toxoid component administered. So do you think we need the 90461 or should we only report 90460? John, are you saying yes to both or yes to just the one? Report both. Yep. Because it's going to be for the components, not just how many injections were performed. So because there are 4 components in the MMRV, then we need to account for the counseling and the administration of each of those components. So we're going to code both 90460 and 90461 with 3 units, and that will give us all 4 components. Okay. Number 9, a patient with carcinoma of the descending colon presents for chemotherapy administration at the infusion center. The infusion was started with 1,000 cc's of normal saline. Heparin 1,000 units was added, and then Fluorosil 800 milligrams was added and infused over 2 hours. Dexamethasone 20 milligrams was administered as an IV push, and then at the end of the 2 hours, the IV was disconnected and the patient was discharged. So I like to, when I have all of these drug codes, right, because I have multiple drugs, I'm going to go straight to J codes. Okay, Dawn says she would have gone to ICD-10s. You can do either one. Yeah, whichever one you're more comfortable with. So let's look at this from a J code perspective, because again, we haven't really done a whole lot with HCPCS. Okay, so let's look at this from a J code perspective. We have all 4 codes or all 4 options have J9190. However, if you notice, 2 of them have 2 units and 2 of them have a single unit. So let's go to the J9190. And then our code description for J9190 is for the injection of the Fluorosil, and it's 500 milligrams. So we have this Fluorosil that we did 800 milligrams. So do we think we're going to use a single unit, or do you think we should use 2 units of the J9190? 2. Yep. Because we have to account for all of the medication. So if we were to only bill 1 unit, then the provider would not get billed, or they would not get paid for 300 of the units that they administered. Okay. So next, the J1100 has 20 units for both. Okay. So we're going to kind of skip that one for now. And then we have J1644 in just one of our options. So let's go look at the J1644. And that J1644 is for the injection heparin sodium per 1,000 units. So we have heparin 1,000 units, which means that we should use our J1644, and we have our answer. Okay. Any questions on that one? Okay.
That's a lot of codes.
It is, but you can see that we really only had to look up 2 codes, right? So that we definitely helped from a process of elimination standpoint. We got you to where you needed to go with just 2 codes and not make it so intimidating from a testing standpoint, right? Okay, let's do our last one, number 10.
So Tiffany, just a quick question. So when they mention drug medication, the medicines rather, we have to always code those, correct? It's never
Yes.
where we have to eliminate any of those. Am I right?
Yep.
Okay. Just clarifying that.
Okay. Yep. The only time that you wouldn't code them separately is if for some reason there's a J code that includes both of those drugs in a single code. Like if it's a compounded drug, then you would code with the single code versus double.
Okay. Got it.
Yeah. Good question though.
Thank you.
You're welcome.
Mm-hmm.
Okay. So let's do number 10. Patient has had several panic attacks at work and has disturbed her coworkers. She has been unable to explain any particular reason for her behavior. Her employer requested that she be referred for counseling. After several sessions, the psychiatrist has provided reports for her primary care provider and her insurer about her status and prognosis. So what CPT and ICD-10 codes should be used for the preparation of the report? Yep. So Dawn's on it. Dawn's already figured out that her panic attacks are going to be F41.0. So if you're coding it from scratch, you can go attack and the ICD-10. And then underneath attack, go to panic, and that gives you F41.0. Okay. So I'm just going to go look at the code. Not that I don't believe you, but I always like to just look at the code, make sure that code description matches everything correctly. So F41.0 is panic disorder, and then you've got your includes notes underneath that state panic attack, so we know that that's good. So our F41.0. And then we're going to go back to our CPT book. And we're going to decide, do we need 90889 or 90885? So 90889 is going to be for the preparation of report of patient psychiatric status, history, treatment, or progress for other individuals, agencies, or insurance carriers. And then 90885 is going to be for the psychiatric evaluation of hospital records, other psychiatric reports, psychometric and/or projective tests, and other accumulated data for medical diagnostic purposes. So what do you think? Should we use chat says 90889. Does everybody agree that we should use 90889 for that report that the psychiatrist provided? Okay. We got through all 10 again. I'm proud of us.
All thanks to you.
Does it seem like it's getting easier for you guys to see them and rule them out and comprehend them?
I don't know. I just think this is proving to be a lot harder than I expected.
Yeah.
I can admit I felt really discouraged that with the coding from scratch. I'm thinking, did I make a mistake even picking this?
Well, and again, it's going to be one of those things that coding from scratch, the more you do it, the more confident you'll get.
Because it's very confusing. confusing
Go ahead.
coding from scratch because like I'll look at the pre-operative and post-operative diagnosis, and then it's just like one in chapter 6, it's like a radial fracture, I think.
Mm-hmm. Yeah. So when you're coding your fractures, it's important to make sure that you know whether it is what type of fracture it is, whether it's open or closed, your anatomic location, all of those things, right? So just make sure that you're following your alphabetic index as far down as you possibly can with fractures, because I know fractures can get a little muddy. Um, but just keep practicing. I mean, that's really, I'm sure everybody here has been in that point, where they feel like they're stuck and they've questioned their sanity and all of their life choices. I know I've been there from a studying perspective. And once you just practice it more, one day you'll wake up and it'll just click, and then that practice is going to be worth it. I know it's frustrating now. I have been in your shoes. I think all of us have been there.
Yeah,
But I mean, I just
and
can't
I'm
reiterate that practice is what's really going to get you more comfortable and confident.
because I can admit I get stuck on those that event that I look at the answer key. And I know
Yeah.
I know I can't do that all the time. It's just I can't help it.
Well, looking at the answer key can give you so that you're not just sitting there and just spinning out, right? Looking at the answer key will give you some guidance for sure.
Yeah, I mean, like the concerns I have is like for when I worry about for since I don't know when I'm exactly going to be ready to take the CPC, and I don't know when I'm going to start taking the practice tests again. Then then there'll be the fill in the blanks on the official CPC exam.
Well, I don't think that's going to come until January. Okay. Again, that's all pure speculation, but you've got
That's what
at
I'm.
least 5 months now. So you've got plenty of time to continue to practice.
I just hope that by the time January rolls around, it's just I don't want it to be terribly long. I'd like to take it sometime this fall.
Yeah. Yeah. Just keep practicing and just keep up at it. That's all you can do.
Okay. Will there be more study sessions?
Yeah. So once we finish, we'll do anesthesia next week, and then we'll do ENM the week after that. And then we'll start back over with ICD 10 in 3 weeks. So
Great,
we're going to just kind of make a circle and just start back over.
great. It's really with this personal thing that's going on in my life that's unrelated to coding, and then with this and uncertainty, it's just a lot. It's just making my mind race.
Yeah. Yeah. We'll get you there.
Thank you. I appreciate you, Tiffany. I appreciate
Yeah,
this whole
of
group as
course.
well.
Absolutely. So you guys have
Thank
a
you,
good rest of
Tiffany.
you're welcome. Have a good rest of your evening this Wednesday, and then we'll chat with you next week. Y'all
All
have a
right.
great week, okay?
Good night.
Thanks.